How do social media, mobile devices, medical devices and implants, online health websites, and clouds threaten health privacy? My name is Steve Steffensen. I'm a neurologist by training. I have sort of multiple hats that I wear, like many people on my panel. I'm an assistant professor of neurology at Johns Hopkins University, but I'm on loan to the Department of Defense, where I manage the largest health IT research and development portfolio for the Department of Defense. And we have been actively invested in the privacy area for a number of years, mostly working with the VA. Some of you may know Mike Davis in the VA, who works with OASIS on some of the technical aspects of Exacamol and EXPA and other things. I think we're also waiting on, is Lee here? Yeah, Lee's not here yet. Within that role, privacy, we really started thinking about privacy, thinking, you know, we're trying to be innovative in IT, and we're really falling short is being innovative in areas of policy. And if we're not innovative in areas of policy, at the same time we're trying to be innovative in technology, obviously technology will always outpace policy. So how can we start to be innovative in areas of policy? And that's really where we started looking at venues to have the kind of dialogue that I think has occurred here over the last 2 days, and we hope to continue with this panel, is to really engage the privacy advocates in the community with the Department of Defense to actually understand what the issues are so that we can begin to instrument policies or adjust policies where they need to in order to fit the needs of patient privacy. So a couple of misperceptions about the Department of Defense that are sort of useful to sort of discuss before turning it over is that one is we are not the same as the Department of Veterans Affairs. It's completely separate departments, completely separate missions. And if you just think about that, that makes sense, I think, for everyone. We have roughly 10 million beneficiaries that Captain Wiener talked about. Of those, only 20% are active duty. So only 20% actually wear a uniform of that 9.8 million or so, which means that the remainder are the spouses, the children, and the retirees. So our patient population actually looks a lot like every other patient population. That's very different than the Department of Veterans Affairs, who are all veterans. For the most part, with few exceptions, they don't see pediatrics, for example. And only recently have they started really, in the last 10, 15 years or so, really started engaging more in the obstetrics gynecology work that they've had to do as more women have started joining and becoming veterans. Obviously, the wars that we're currently engaged in have changed the dynamics of some of this, and the VA is starting to see a much broader group of patients, and there's a lot more collaboration now between DoD and VA and our patient populations. So I wanted to sort of throw that out. I'm based at Fort Detrick, Maryland, up in Frederick, Maryland, at the Medical Research and Material Command, where I spend the majority of my time when I'm not working at Johns Hopkins. So without further ado, I do want to run down the panel very quickly, and Lee joined us, and just give people a chance to very quickly introduce who they are and where they come from and the perspective that they sort of bring to the table, and then we're going to open it up to questions. The way that we've designed this and when we're having our meetings is that there happens to be 5 different sort of areas within the panel discussion, and so we've divided it up into 5 separate questions, one each for the panel members, recognizing fully that another panel member may have an idea in social media, for example, or in mobile devices. So we're going to go down the row. First, just introducing yourself if you could, and we'll start with Nick.
Nicolas Terry. I'm the Hall-Render Professor of Law at Indiana McKinney School of Law in Indianapolis, and the Director of the Hall Center for Law and Health. And as an academic, therefore, I really don't know anything about any of this, but I'm extremely grateful to Deb for the kind invitation and for Steve's help in putting this together.
I'm John Neiditz, and I lead a practice called Information Management Law at the law firm of Nelson, Mullins, Riley, and Scarborough. And I have been deeply involved in health privacy for quite some time as a consulting practice leader prior to getting into the law firm world. And I am deeply involved in big data, and we'll explain it a little bit more than was done yesterday, and we'll be talking about cloud here. We can hopefully have a lot of interaction here, even though it's being recorded, because what this should be about is disruptive technology. That's the opportunity that faces us now.
I'm Devin McGraw. I'm the director of the Health Privacy Project at an organization called the Center for Democracy and Technology. It's a nonprofit, public interest, civil liberties organization. We mostly work here in D.C., although we also have an office in California. I do work on policies to promote health privacy and security as we move healthcare into the digital age, but CDT also has an initiative on consumer privacy on the internet, and so many of the issues that we'll talk about today kind of really touch in both spaces. So I'm looking forward to the conversation as well.
I'm Adrian Gropper. I am a medical device developer, serial entrepreneur, not actually involved in a venture for the last year or two. My principal perspective is a technocrat. I'm genetically an engineer. I've never actually practiced medicine. And so I've been involved for many years now in a number of policy and standards and technology-related issues around health IT.
And I'm Tien. I'm a senior staff attorney with the Electronic Frontier Foundation. My organization is specializes in digital civil liberties, including privacy, intellectual property, and free speech. Because we do digital privacy and also security, we've got an arm of our organization that does a lot of its own technology. We've got cryptographers and security researchers on our own staff. So for that reason, when the health privacy area began to blow up, then we decided this is an area that we should be working on. And for the last 3 or 4 years, I've been very involved in the state level in California, which is where we're based, working with their EHR and HIE projects. Thanks.
All right, so the way that we've divided this up, we have, again, sort of 5 generic topics around social media, mobile devices, medical devices and implants, online health websites, and data clouds. What we're going to do is actually divide this up and give 1 question each to each of the panel members, give them a brief period to sort of comment, make their opening comments about that, and then open it up to the rest of the panel to provide some comments, hoping to spend 5 or so minutes on each topic, which is going to be a little bit challenging, I think, for all of us. What we'd really like to hear, though, is some of the questions and create some of that dialogue with the audience as well. So the generic question that every member is going to get in each of their 5 different areas are, what are the problems facing privacy in the domain of X, whether that's social media or mobile devices? And then commenting on sort of cultural, legal, and or technical issues, as well as possible remedies that are on the horizon, trying to think about, okay, so that's the problem. Let's not all just complain about the problem. What are potential remedies that we may see? We're also not necessarily focusing on the healthcare space, although there's an obvious emphasis potentially on healthcare. We're sort of interested, too, in the generic issues facing privacy that are applicable to healthcare in these domains that are typically thought to be outside of healthcare, but are increasingly merging with healthcare, such as social media websites, where you heard people posting their cough, like Captain Wiener mentioned. And then also considering mentioning case studies, historical accounts, or cautionary tales that may help illustrate the problem for the audience who may not be used to thinking about these 5 different domains. So the first question, again, what are the problems facing privacy in the domain of social media? We're actually going to give this one to Nick, and I'd like to sort of to couch this. There's been some recent news items that I was benefited from on my long drive in from Frederick today about LinkedIn, for example. And some of you may have heard on the news about 6 million different records of their 150 million that are now potentially compromised. Granted, maybe encrypted on some out there somewhere, but nevertheless potentially compromised. Also yesterday there was a nice article about Facebook and the fact that when you like a particular, say, Coca-Cola Facebook page, that actually they can begin to use your face or your profile in ads to your friends. So that when your friend's Facebook page now, they could actually have an ad for Coca-Cola that shows the fact that you liked it. And I think that has interesting implications in the healthcare space if you like the AstraZeneca thing, for example, right? Now does that suddenly show up and now your friends know that you're maybe taking a medication? So Nick, I'll turn it over to you. Social media, what are some of the problems facing privacy in this domain?
Well, thank you very much. I'm not too sure of the details about the alleged LinkedIn security snafu. All I can tell you is that I now have 427 new friends in the Ukraine.
Yeah.
So, like, you read the title of the program, right? Social media, blah, 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 blah. The next line is much more important. New technologies, many of which are outside of the healthcare system. And that's what I think glues all of this together. And for me, that sort of opens up sort of 3 interesting themes that we've sort of maybe missed a little bit or played only a little bit with at the conference so far. The first of these is some of these players, maybe all of these players, will not be covered entities. Or, as it's sometimes expressed, the data stewards that we're going to be talking about exist in a HIPAA-free zone. The second sort of implication is that this whole conversation doesn't map really very well to what the wonderful Joy Pritz said the other morning about U.S. healthcare policy and regulation being dealt with on a sectoral basis. Because almost by definition, we break through that sectoral model here. The data is refusing to stay in these domains that we are describing. The third thing, I think, is we're likely dealing with personal information, not necessarily personal health information, but personal information, which, as Frank Pasquale called it the other day, may be medically reflective. And I think that, again, is common to the pieces that, or inflected, excuse me, that we're talking about. So, as you know, that there is also as an attempt to sort of broaden this out a little bit and take us up over privacy more generally. As you know, the conference is being tweeted, and I actually follow Martian HIT commentators, and it was really interesting to see their reaction to the tweets that have come out of the conference. And one of those reactions was hilarity that it all seemed to be about electronic medical records. And the privacy implications of electronic medical records and how upset and the various sort of things we were using to lash each other with regard to electronic health records. I mean, I think meaningful use isn't going very well. I think we're still in a cheerleading phase. I think when we've spent all the money, we won't have very good electronic medical records because electronic medical records at the moment are not very good and won't be very good for a while. I don't think they will talk to each other very well. They don't seem capable of it at the moment, and I don't think they'll play very well with the other modules in the hospitals that we want, like really good clinical decision support. I think we're going to see vertically integrated models doing very well, but that would be a very small percentage of the total number, and most of the health care that most Americans receive, or for the uninsured don't receive, other than an emergency room, will not be EMR powered or anything like that. So I think that this area is really important as far as...
So let me sort of bring this back to the rest of the panel members too, because I think that so these are some of the issues, and when I start to look at the issues facing privacy on the social media stage, we don't even really know yet what all of those issues are going to be sort of moving forward and how those impact potentially healthcare from this sort of inflectives, or where you can make inferences about the state of somebody's healthcare. What are some of the, in your experiences, the experts on the panel, my opinion is, so what is sort of your experience on, well, what are some of the near-term things that we can do? Is it an educational thing? I'd be sort of interested to know from the rest of the panel on some of the things that they see as ways to not just identify the problem, but maybe start to work through some of the issues.
Well, he didn't just identify the problem; he identified some of the solutions too. Yeah. And you know, it's wonderful that he started this with telling the truth. You know, and so that hopefully will be a theme of this session. You know, when you say that most of healthcare won't be vertically integrated EMRs, right. My life is a twofold life, which is in part instituting these very difficult big picture things for big organizations, which is slow as all get out, and then disruptive technology, which is coming in at the app level, better, faster, much cheaper. That's the revolution. That's what's happening in healthcare right now, and we haven't talked about it here in this session very much, and it's because it hasn't made it through into a lot of the dialogue here, but that's what's happening. So when he was not just posing a threat, he was talking about the reality of very low cost disruptive health technology reaching the 90% of the people in the world who have cell phones in the world.
Right.
Yeah, I sort of think, if you think about it, it may take the provider community quite some time to reach as Nick was saying, to reach this sort of ideal state of exchanging information. And in the meantime, there is an amazing revolution. It feels like a revolution. Maybe I'm just a little too close to it, so it feels like it's bigger than it is. But in the e-patient community of people who are hungry for information about their health, who are increasingly using internet-based tools to communicate with others about their health, to learn about their health, to manage their health, and it's all occurring outside of HIPAA, of course, and minimal regulatory oversight from the Federal Trade Commission, and so there are risks associated with it, but there's that enormous disruptive potential to it as well, that is the eye on, that's the prize we need to keep our eye on, right? So how do you let that space happen in positive ways, but not threaten people's privacy while we're getting there? Because we will leave out a significant portion of the population if we can't give them some sort of guarantee or protection for their data, so that the privacy nervous can be in that important space as well.
Well, I think Nick said it very well, that the EHR is the wrong way is over. Whether or not the next $20 billion that will be spent, you
heard it here first, folks.
Yeah. And it was interesting because I tried to make this exact point, 15 minutes ago to the doctors, and the doctors do not see it that way.
Not all
well, and I don't
doctors.
either,
Come on,
Adrian, just so you know.
But let me just say why, or not why, but what the solution, since that was the question. I think I'll start with just a very great quote from David Weinberger, who teaches at the law school at Harvard, who talks about the fact, with respect to social media and things, that the smartest person in the room is the room. Is I think the quote from him, that the age of the expert is rapidly drawing to a close, and the social network, the people in the room, the people in your care team. And so what I'm saying is that there's a choice that we will have from a privacy and from a patient perspective, which is, do we go for things that make the data easier to share with the room, with the people that we want to share it with, certainly not in an uncontrolled way. I think Ross Anderson spoke brilliantly about the actual things that have to happen, and not about the EHR and the closed system, whether it's at the level of 2 doctors or the entire DoD.
So Lee, the next question is actually for you, so maybe you can play, if in your response, maybe you could comment on some of the action here. And really it's around sort of mobile devices and what are some of the problems facing privacy in the domain of sort of mobile devices, and not necessarily related to healthcare again, but and we've already been touched on this a little bit, in the fact that sort of where is the market moving from a mobile perspective. I have a colleague of mine who jokes in his presentations about, someday our kids are going to be saying, when people used to go to conferences, they used to carry these big bags that would roll on wheels and stuff, and they had these like things that they would set out on top of their desk and everything, and why did they do that? And they also used to do this thing called email, and email is just how did they even get by with communicating, and if you look at the generations coming through now, email is not the primary means of communication anymore, right? And how, as a large enterprise business entities of those in the room, are we adjusting to that, and what impact will that have in the healthcare market in terms of privacy? But from a mobile perspective, we have some recent events. Obviously, you can take your choice that I'm sure Lee will maybe expand on, but from the iPhone tracking exactly where you were. I have a personal history of this, where I was moving across country from Austin, Texas, where I live, to Maryland, and then the report came out about the iPhone tracking where you were, and they created an open heat map app that you could download online and actually see the data displayed on a map to show you what data it was collecting. It was amazingly accurate. When I would pull off the road to a rest stop, it was amazingly accurate in my mind. Complete timeline. Showed exactly where I was when I went to a friend's funeral in Oklahoma and back down. You can actually do the timeline for those who have seen it. So I think, obviously, there are these things that are unintended too, that we now have apps that are tracking information about us or uploading our contacts and those sorts of things. So Lee, I'd like you to comment on mobile devices in particular and some of the risks to privacy.
Right. So this is an excellent segue actually out of social media, because one of the things that mobile devices share with the whole area of social media is that these are things that we do on the internet, and there is a baseline privacy problem when you do anything on the internet because of the phenomenon of online behavioral tracking, mainly driven by advertising seeking to monetize the clickstream data, right? So your IP address, what websites you have visited, what parts of websites you've gone to, and just like Steve was talking about how the phones will compile location, there are multitudes of companies out there that are collecting that sort of information whenever you interact on the web, whether or not it's via a mobile device or not. If you've seen the Wall Street Journal series, about what do they know, you know that when you visit a newspaper site like the Washington Post, there's anywhere from an average of 65 to 100 different servers and domains that are not the Washington Post that are collecting information about what you do. So that's just sort of the baseline problem when you talk about internet at all. And so it's not just the ad networks and the analytics companies and the ISP that you are using to access it. It's also the embedded social widgets, right? You go all over the internet, you see that ubiquitous Facebook like button. If you're a Facebook user, Facebook is capable of knowing every site that you visited that has a like button on it. It's, that's social surveillance. Now, mobile devices add a couple of additional problems, and the large sort of chunks or categories of those problems are: one, there are more players in the area, and two, there's more information that's going to be sucked out of you. So as far as players go, you think about your iPhone, you think about your Android device, you've got an app. Well, who is it that made the app? The app developer has a channel into your data. The mobile OS platform, is it Apple iOS? Is it Android? They have information about you that they can take off of the device. And even the handset vendors, when you go outside into the area of, say, Samsung or HTC, we represented a security researcher who discovered that on these kinds of Android phones, there was diagnostic software called Carrier IQ. Turns out that in a number of configurations and settings, the Carrier IQ software logged every single action that the user took on the mobile device and sent it out to Carrier IQ, who was essentially acting as an agent of the carrier for quality control purposes, but also had relations with the handset manufacturer. And apparently it was in some sort of, their initial story was that it was in a diagnostic mode and it wasn't supposed to be doing that, but there was a big furor over exactly what Carrier IQ was doing. So here we see that there's additional complexity to what you normally have on the internet. And then you add to it and this is implicit in what I just said, there's more data. In your typical desktop computer or laptop, there's only certain amounts of information that are easily accessible, and that's mainly through your user agent or client or browser. But because of the nature of the mobile device, where the platform is the operating system for the entire device, then you're talking about the address books. The Facebook mobile app was able to simply copies your phone address book to your Facebook account. And, they disclosed this, but nobody realized it. And so, boom, that's all there. A company called Path, which is a much smaller social media company, did the same thing. Text messages on your phone. Studies have shown essentially that these apps do collect things like the unique IDs of your devices, your age, your gender. Steve's mentioned location. There's really an enormous amount of exposure, and mobile devices have the worst security because people are cycling through to create these apps. They all want to be the next Angry Birds, so the incentives to be careful with information and the incentives to monetize data are very high.
And I want to be a little sensitive to time, and I know some of the other panel members may want to comment on this and just be trying to get through some of the other topics. So again, those are some of those issues. And what are we to do, right? In terms of everybody in here, I'm assuming, probably has a mobile device on.
Well, he didn't even mention, and that was a great description of the issues, but he didn't mention how big the issue is. So the issue is so big because the mobile device is the primary theft target in America today. That's why the Federal Communications Commission is partnering with the carriers to do a national program where these things are bricked as soon as they're lost. Because there are studies that show when people find these things, what they do is they immediately go right into your Google Wallet or your ISIS wallet, and let alone the medical information that's there. And so this is but understand this: these are the medical homes of the future.
Correct. And Devin,
you heard it here first.
And Devin, you had a comment, it looked like, too? Did you have a comment too, Devin? I'm sorry.
Well, so one of the things that that I wanted to explore in Lee's comments, and there were lots of things there, is the idea that what we use to place some controls on this information today is essentially the privacy notice that people or terms of service that people then click and agree to. So he noted that with respect to some of the Facebook issues, at least for some of them, they told people, but people weren't aware of it, either because they didn't read it or they read it and they didn't fully understand it. And there's probably folks in either camp, and yet we continue to rely on this sort of, here's what we're doing and check the box if it's okay, or if you even get that some of the time.
I think there's an interesting distinction too that he was making between the OS and the apps, because for example in the OS, if I want to continue to use my phone, I have to download the update for the OS.
You don't get choices about everything.
And so it's a sort of, you get this partial choice, right, where it's like eventually the version you're on, if you don't continue to uptate it, will be non-existent anymore. And
you don't get any privacy policies associated with the apps, for one thing.
Yeah.
The Facebook in 2012, quote, "We've renamed our privacy policy as our data use policy. Because we and experts we consulted believe the name is more descriptive in the information the document provides." Andrew Brown, writing in The Guardian 2 years ago, "The whole point about Facebook is that users aren't customers. Anyone who supposes that Facebook's users are its customers has got the business model precisely backwards. Users pay nothing because we aren't customers but products. The customers are the advertisers to whom Facebook sells the information users hand over."
So let's move on to Adrian, who's going to address the issues around medical devices and implants. And I know that within DoD VA, for example, there's been a lot of funding in labs like the Summit Labs up in Boston, which you may be familiar with the Integrated Clinical Environment, which is trying to figure out how to make medical devices interoperable, because there are tremendous issues around losing data simply because the daylight savings time, for example, during daylight savings time, you lose an entire hour's worth of data because the clock automatically gets reset and it overwrites. So there are issues where standardization is important, but what we're seeing, especially in our space, increasingly these devices are becoming networked. And now there's information that the device manufacturers want about the patients on a network device where standards are loose. And I'd like you to comment on that.
Well, let me start with the answer.
Sure.
Because it'll focus the comment, which is the answer is voluntary identity or anonymity or both. And we can go into what that means. It's quite technical, but I think that is the short answer. Now, let me just try and frame that very quickly. If you want to think about devices, or let me put it this way, the way I think about devices is about the person. And it's not even a patient.
And it's blurring, too, with mobile devices, right? We're seeing this blurring, obviously, which is a nice segue.
I'll get to it.
Yeah.
Okay. So I just, three kinds of devices, this is very quick, that I think we should all have in mind. One of them is the blood test, let's say a tox screen that you might get in the ER, where that result nowadays goes to the EHR and is pretty much out of your control, though the federal government is doing a lot to change that by at least giving you access to the results at the same time. A second kind of device is Hugo Campos implanted cardiac defibrillator, where the information from that device goes to Medtronic, I'm not sure if it's Medtronic, but to the device vendor like the person IQ.
Carrier IQ, yeah.
Carrier IQ, and from there maybe it ends up in the EHR or God knows where. And then the third one is the blood pressure machine that I use, where the result goes to my personal computer, and then I share it with my physician and their EHR if I choose to. And what I'm trying to say is that the only common denominator about all of these are all devices, including that tox screen that was done and sent directly to the EHR. They all end up in the EHR, and the only way to make sense of it, in my opinion, from a privacy perspective and to solve the problem, is to think of the fact that it's just the person we're talking about here, whether it's blood, whether it's the output of that ICD, or whether it's the phone that tracks where you went across country. And therefore, we have to pay a lot of attention to how we're identifying ourselves to the rest of the network, whether it's Carrier IQ that's tracking that device serial number, or
So Lee, I know that because of I see a tremendous overlap as I have to think about investments in these areas where things like the FDA and FCC overlap, for example, in areas of policy where suddenly a communication device is now becoming a medical device, isn't it? And I'd like, what are your thoughts on what Adrian has said?
Well, I mean, I think Adrian is right on the sort of on the privacy side of it, but I think again, my concern is with the security side of it as well. I mean, in one of my other hats, I represent security researchers, and one of my clients is a team from Amherst and UW who basically discovered a bunch of securities relating to implanted medical devices, defibrillators, right? This is 2009. They actually, stuck something into like a cow heart and showed how they could feed it all sorts of interesting signals, cause it to shock the patient, et cetera, et cetera. It was insecure. So why does this exist? I think it's really important to think about it. And the ISPAB, which is the division of like the National Science Council or some ISPAB, they recently sent a letter about medical device security to the FDA. It's a very, very good letter that really summarizes it. But I mean, the basic problem is that you've got a mature industry of medicine or health that's coming into the internet age, and they don't understand security. I mean, they just don't understand how hard security is. And the baseline problem, as we've seen in all areas of cyber, is that the incentives are mismatched. When you talk about implanted devices or any of the medical devices that Adrian was talking about, you've got connectivity problems, which means you're talking to the internet, so there's attackers. And then they're wireless, so that the channels themselves aren't necessarily secure. Third, they're often going to be outside of the hospital environment, especially if they're implanted. So the environment is uncontrolled. And then at a ground system level, we have complex payment schemes where, different people are paying for, responsible for things, and there aren't any clear regulatory lines in the government. So there's a big failure here.
So one of the themes last year that I remember too, and it was brought up earlier yesterday, and we didn't really get a chance to really go into it, but I think you're sort of hitting on it here, is the differences and similarities between what we call privacy and what we call security in this sort of context. And I think that it's particularly in the area of medical devices, I think you are, and I don't want to put words in your mouth, but it does seem like the security issue seems to be maybe just as important in terms of all the different mechanisms of attack than...
You have to have both, right?
Because it's connecting with your body rather than with your mind.
Right.
Well, until you get the brainwave device, right? Yeah.
Exactly.
Right. Which I can neither confirm nor deny.
I think we have an interagency problem that is in the background here. I mean, we know that ONC and FDA have had disagreements as to the extent to which EMRs should be subject to safety regulation, FDA regulation. It's unclear whether the FDA roadmap for regulation of mobile medical apps is going to have the sort of the FCC sort of security or FTC
Or FTC.
privacy sort of back end. And we have federal legislation, proposed federal legislation at the moment, that says the entire roadmap should be delayed. So an awful lot of indeterminacies, not just as to the granular nature of security and privacy regulation, but sort of the meta questions as to who are going to be the players and stakeholders in setting that.
Right, absolutely. And that's sort of what I was saying about this FCC FDA joke that we have inside our department, at least. It's like, okay, tell me who's going to guide this then.
Right.
Because, all right,
let me just make one very quick comment about that. I don't want to... because I deal exclusively in FDA-regulated medical devices. One of the things that makes this very hard is the fact that regulated medical devices are assumed to be sold by physicians, whereas everything we're talking about here equally, and all of us I think would agree, apply to things which are, like somebody said, designed to be outside of HIPAA.
Yeah.
Designed to be sold directly to patients. And that's the only thing I'm going to say. There's no right answer here, but we have to be cognizant of the fact that the FDA will either have to change from the security and safety point of view, or they will
going to be
have
driven
get
out of the markets and the app development.
Or they will not change and they'll simply let the market.
So it's interesting. We get to play with a lot of toys at TATRC, and people bring us all kinds of new technologies and everything. And one of them that came to our attention recently was an app that you may have seen that using the light on the back and the camera on the back of the phone can actually detect your pulse. Yeah. Have you seen those? That's amazing. I mean, to me, and it's like, so we start to venture into areas that actually get outside of the phone itself now is doing something that traditionally a connector would have to do, that you could maybe qualify as a medical device.
Well, no, I actually have to say this since you brought it up. Because it is a privacy conference that we're at, Philips will sell you an app now that detects your pulse by looking at the picture of your face, because it's detecting the subtle color changes. And so now you could be walking through the door of the Georgetown Law School, and somebody can be looking and knowing what your pulse is.
Well, that's what they were doing in Singapore, right, with SARS, right?
Yeah.
They were actually trying to detect that.
Yeah. Based on, So I think, we're bringing up a lot of issues, I think, with all of these questions, and obviously none of us, I think, have the definitive answers, and we're hoping to sort of get down into that. But let's move on to online health websites, and health websites was put in quotation marks in the panel. And I think that's sort of interesting because you think about web pages where patients go to actually get medical information, and who are the trusted parties. I had dinner last night with a few people who we were talking about this. Unfortunately, I had to go to a separate dinner last night, but this issue came up of trust and the fact, and I used to deal with this a lot in my neurology practice, where I would be seeing patients with complex daily headache, or what we call analgesic rebound headache, which is the headache is actually caused by taking the over-the-counter medications for headache. And so they have to trust me over the advertisements that they're seeing on a much more routine basis. And so where they're getting their information and the trust fabric is actually very difficult for me to compete with when I'm seeing them once a month, once every other month. So I think there's some interesting implications of the online health websites from that perspective, from a trust perspective, but also in this ad space idea that we sort of talked about before. So Deven, I know you have a lot to say on this. I'd like to hear sort of the privacy issues, if you could categorize them, and how do we begin to think about that?
Yeah, I'll try to, and I'm just going to kick it off. I'm sure my fellow panelists will have some things to say about it too. The category of online health websites that bleeds over a bit into some of the social media, because a lot of the online health websites offer not just information but opportunities for patients to sort of log on and share information. So, the Pew Internet Foundation has done the best research, I think, on sort of how often people are using the internet and online health websites, and so we know that 80% of internet users use the internet in order to search for health information, and a lot of them are getting that health information from health websites, and sometimes that's just through browsing. But as Lee mentioned, of course, when you're browsing for health, whether you're on a health website or you're just picking up content on the web, that information is being picked up and tracked and shared and used for advertising purposes. But of course, there's also the information that the patient on the online health website actually enters onto the site or willingly shares on the site in a direct way. And that information, again, what it's used for is not always well known to the patient. Ideally, it's disclosed in a privacy policy, but people don't always fully understand what those are, nor are you necessarily provided with a set of choices about that. Sometimes it's kind of take it or leave it, right? So if you want to use the benefits of the site, here are the terms of service if they're even obvious to you, and either you agree to those or you don't use the site. And quite frankly, people are getting an awful lot out of using these sites. And so, notwithstanding that there are privacy risks, we're not going to address those by saying, well, we have to shut these things down. We have to find a way to create an environment that allows people to get the benefit of it, but doesn't sort of subject them to the wolves, quite frankly.
So I think in the spirit of time, I would like to maybe combine this with what John was going to address in terms of data clouds, because this data that's being collected from disparate sites, I'd like sort of the definition of that, because we had heard a little bit of a different definition of the cloud sort of theme, and of course I have my own thoughts, but I know, John, this is an area you've heavily worked in. But now that we're collecting this information is going between multiple different parties. When you hit the CNN website, as Lee was talking about, if you look down at the little thing down at the bottom that's loading everything, you can see googleapis.com. You can see all these things being loaded in the background. That information is going somewhere, and I'd like to hear some of the implications, and maybe we can merge the last two topics a little.
Okay, so look, what I'm going to try to do is first to tell you what the structure is, the technology structure that creates the risk in cloud. So you understand cloud better than you understand big data from listening here. And the last panel was wonderful for those of you who heard the last panel, because you had a wonderful mixture of perspectives, with people indicating that big cloud providers may be the safest place for information. But what's the problem with the multi-tenant server public cloud, and what do I mean by that? What I mean is that instead of having control over the ultimate physical servers where the information is going, all you have are contracts with computers all around the world. So you have the full computing power of the world at your disposal. That's what the multi-tenant server public cloud is. What does that mean? Those computers in China and in the rest of the world are backing up little pieces of your data, because the other thing about cloud is it uses virtualization. So there are replications being made of your data all over the cloud. So in China, during their daytime, they're working for you. And during their nighttime, they're working for you, and they're backing up the data onto their servers. That means pieces of your data are backed up onto their servers, and that means and they're not visible anymore in the cloud once they're backed up onto their servers, and that means you can't securely destroy them. So the basic difference between multi-tenant server public cloud and non-cloud is the inability to securely destroy. So you say, is that illegal under HIPAA? The answer is no, it's not illegal under HIPAA at all. Why? Because HIPAA security is not as sophisticated as PCI DSS security. PCI DSS says destruction is much better than encryption, because the sensitive cardholder data you have to destroy immediately. But the primary account numbers you have to encrypt to PCI standards. But HIPAA, high-tech, says, for purposes of the breach law, destruction to the Secretary's standard is at the same level as encryption to the Secretary's standard. So you can encrypt everything and put it on the multi-tenant server public cloud. That said, what those of us who've been working in this area have been doing for the last 4 or 5 years is dealing with the cloud providers, hitting them with all the regulatory issues that they face around the world, and getting them to introduce a panoply of levels of control over the information, which all comes down to that one issue that I was trying to teach you at the beginning about control over the ultimate physical servers. Okay? So, as a result, what do you see? I thought this first panel that preceded our panel was going to be saying, oh, the cloud is taking the thing away from the doctor-patient relationship, the doctor's office, the sacred doctor-patient relationship. Well, the fact of the matter is that the poor doctor is sitting there with a computer, and that computer is infected. And the doctor has an IT person who comes through periodically and tries to fix the computer, but that's over, just as certain other things you've heard about in this panel are over. And what the safest thing for that doctor is to get the information out somewhere where they can actually do the kind of security you have to do on a day-to-day basis. And the type of security that is you have to know that your system is vulnerable and is probably infected. And so you don't just monitor the infiltrations of the bad stuff. You have to monitor the exfiltrations. And you have to snip the cords of those exfiltrations because the information is trying to get out. The reason you don't have lots more data breaches publicized in the healthcare world is because the healthcare world doesn't know that it's having data breaches. And that's because they don't have those data loss prevention systems that monitor the exfiltrations.
So that brings up a good, I completely agree with that, actually. And we've experienced our own issues in terms of data being remote, largely because of complications in our networks having to hop between different secure nodes, et cetera, which does actually slow things down. I know there was a little bit of that panel discussion before, but having been on the receiving end of that as a practicing provider with our EHR and suffering through some of that, I can say, that being said, I completely agree with that. I think one of the things that we brought up as we were preparing for this panel was, again, the very passionate sort of discussion around some of the topics here. And I'd like to open it up maybe for a few questions. But before, I introduced this topic as one of the two physicians on the panel, I think, that a legal phrase that I had heard where are all of these potential threats or threats, real threats, is it a man bites dog scenario? So apparently in the legal realm, as I've been told anyway, and maybe this is completely wrong, but there's this phrase, man bites dog case. And the most common thing is a dog bites man case, but how many of these things are dog bites man? And does it matter? Is that an irrelevant question because just even one event is enough to cause the death of an individual, and shouldn't we fight for that? I think that as we start to think through these and understanding the risks of these potential threats so that we can identify and prioritize how we address these threats. Right now, I think we're sort of in this situation of, oh my God, this is a huge problem, and I don't even know where to start. I've got potential resources I can begin to work through some of these things and have more dialogue if necessary. But how do we prioritize some of these based on where the threats are? And I'd like to hear a little bit about that, maybe. And I'll allow people to come up for questions, but maybe just open that back up to the panel as people may want to come up for questions.
Well, I think as a legal problem, I mean. As we sit and look at something like a privacy issue involving social media or an online world or an app world, the analysis that you'd go through would sort of be serially dog bites man bites dog, and each of those little pieces is going to direct you into a sort of a narrow legal area that you're then going to analyze out. And there may be a HIPAA violation that led to the data finding itself on Facebook, but then the extraction of the data by somebody else from Facebook is going to be a non-HIPAA kind of analysis, and we go through all of that until I think both the technology and the law becomes sort of metadata and follows the pieces of patient information. I'm not sure we're going to have much of a breakthrough in how we analyze that, and we're going to be forced into simply awful and inaccurate metaphors.
Right, thank you.
I would say we're much closer to solutions than you think. We have solutions in all these areas. We don't have time to talk about those solutions on this panel. Kurt back there has some solutions. We all have solutions. And I want to stress that we're talking about the creation of opportunities here. We're not talking fundamentally about problems. The fact of the matter is, I'm going to just talk about big data as a way you solve the problems. So, for example, what's big data? Yesterday, all you heard was big data is big data sets. That's not why McKinsey said a year ago that big data is the hope of the U.S. economy. What they were talking about was massive parallel processing. Using tools like Hadoop that you haven't heard anything about here, and those tools enable you to detect patterns that never could have been detected before. So, in the big data panel, they were talking about fraud as a problem, but did they talk about how you solve the problem in a big fragmented system? The way you solve the fraud problem in a big fragmented system is big data, in terms of analytic tools.
So that may be the difference between cloud storage and cloud computing, too, and some of that, too, right?
Exactly.
Adrian,
it's a two-dimensional problem. And one dimension is man bites dog, what Nick said. You know, you look at it serially. The other one is the device perspective, which is it safe and effective, which is sort of the physician. So we've got the lawyers and the doctors on the panel and in PPR in the space. And this is not about the FDA. I think it is much broader than the FDA, but I think as we go through over these years, we have to look at it as a two-dimensional problem, because that's the way the patient.
So we're officially supposed to be ending, I think, to move to another room. And I do want to give each of you, if you can be very brief in terms of any last thoughts before we move and repeat this session in another room. And remember everything you said, because that was brilliant, I thought. But let's go back through.
Just press repeat.
Any final thoughts before we can?
Yeah, I think, two thoughts. One, everything we've been talking about is a layer of issues on top of the baseline issue of internet and web cybersecurity. We're, all of health IT is sort of an app running on top of that. The second is, from looking at cybersecurity over the years, I think the biggest danger is hubris, going too fast, assuming that we know the risks. When every time we look at it and you move into a different domain, there are risks that are of greater magnitude or of a different order of magnitude than you thought. And when we're talking about health information, I think it pays to be especially careful.
Yeah. I would say, if you don't mind, gentlemen, since you've all spoken recently. Number one, the best we can do for people right now from a privacy standpoint is say, be aware before you share. And that's unfortunate, but it is what it is. And the second thing is, I think John is right. There are solutions out there. I'm not sure we have the proper incentives in place for people to always deploy them.
I'll just say, in terms of privacy, the first and the last thing you should worry about is your good name. And the more we can pay attention to personhood or how we're identified relative to all of this data, big and small, that's being collected about us, the more we will have control over security issues and safety issues and things like that. And that's the place to look from.
And for me, I guess the inner geek, I want to get my iPhone out and take someone's pulse with the flashlight. Yep. But the more sober me says that we mustn't lose track of the idea that health information technology is part of the bigger healthcare question. And we tend to spend most of our time talking about maybe marginal improvements in quality through HIT and forgetting about the other legs of the US healthcare stool of cost and access.
Quality.
And some of these issues, particularly mobile, I think, stand a really good chance of helping us there. But we must, as Devin said, keep our eye on the safe sharing as we do that.
So we need to go cautiously, as everyone said. But the opportunities are tremendous. And I think if we focus on the notion of trust, we will get there working together. And the opportunities for the kinds of interaction and proactivity and new areas of control that people have. When people say, oh, on the autonomy interest needs to overcome the privacy interest, as someone said yesterday. Overcome is the wrong verb. I say pay attention to how much autonomy patients are getting now and how they're using these health websites, how they're using social media. And you'll see the tremendous opportunities we have ahead as long as we proceed cautiously from a security standpoint.
So please help join me in thanking our panel for